now, sir.
Thank you, sir. Good morning, good afternoon, and good evening. Welcome to 1706th day of continuous and uninterrupted Zoom session of IFPH. Let us start today's program with a silent prayer for a minute. Thank you and welcome back. Today we have with us Professor Dr. MOHAMMED IRFAN, MD. Certificates in maternal infants, young children, nutrition, foundation certificate in palliative care, good clinical practice certificate, Professor and Head of Department of Pediatrics, JIMS Homeopathy Medical College and Hospital, Hyderabad, India. More than 2 decades of experience, presentation at national and international forums, winner of many awards. And the topic is role of a homeopathist in palliative care from diagnosis to bereavement. So on behalf of IFPH, and welcome, sir. You can have the platform for the next 40 minutes. Over to you, sir. Please proceed.
Good evening, all. Thank you so much, sir. Am I audible?
Yes, audible. Yes, yes.
Can you see my screen, sir?
No, not started.
Now, sir?
Yes, started. Please.
Good evening, everyone. The topic for today, which I have chosen, is the role of a homeopath in palliative care from diagnosis to bereavement. So today's presentation, I'll be focusing more on palliative care and what is, as a homeopath, what we can do. And today's presentation will be slightly different in the format of not presenting cases totally, but what is palliative care and how a homeopath can be playing a role in the entire process of palliative care. So to begin with this, let us briefly understand what is health and what we are focusing when we are talking about health. So this is the iceberg model of health and disease. What we see at the tip is only the iceberg, which is the state of health. But what lies beneath is what we have to understand by taking a good case to understand why this person is suffering and what is the role of behavioral lifestyle modifications or psychological or changes, or a deeper down a spiritual and meaningful realm of his entire existence. So the other format of understanding the iceberg phenomena is what we focus when we take up the cases is only the physical health, where diet and exercises is what we are focusing on. But deep inside, there are so many other causes, okay, which has to be focused on when we take the cases to understand the person in total. Because individualization is the key of homeopathy. And for individualization, we have to understand the person and not the disease per se. So what we ignore mostly is the environmental health, the social health, the mental health, the emotional health, and the occupational health, which has to be done by an impeccable case-taking format. So what is palliation? Palliation is derived from the palliare, Latin verb palliare, which means to be cloaked or concealed. So basically, the palliate means to cause something to appear less serious or offensive.
Excuse me, sir. Your slides are not moving, sir. Only the first slide is on. Yes, good.
Now, sir?
Yes, palliation. Okay.
Yeah. Did you miss all this, sir?
Yes.
Oh, I'm just focusing on the iceberg phenomena of health and disease, where we have to take all the details of the person, where different aspects of the health have to be considered to understand why that person is suffering. So that is what I was talking about. And to palliate means to cause something to appear less serious or offensive, or to relieve the symptoms of a disease without curing. So this is what we understand as palliation. But why do we need to understand palliative care, and what is the need in today's scenario to understand is what I'm focusing on. So each year, an estimated 56 6.8 million people, including 25.7 million in the last year of life. What we mean by last year of life is the people nearing the death are in need of palliative care. And worldwide, only about 14% of people who need palliative care are currently receiving it. So that is the amount of need of palliative care which is currently existing in the world. And 69% of them are more than 60 years of age, out of which 66% are children. And 80% of these are in the low and middle income countries. And the global need for palliative care will continue to grow as a result of aging of populations and rising burden of non-communicable diseases and some communicable diseases. In India, about 3 to 4 people per.
Excuse me, sir. Could you please go to the next slide, sir? It's only the fourth slide is on. Each time you have to go to the next slide. The definition of palliation is there.
Now, sir?
No.
It's not moving.
I think the slideshow mode is good, I think.
Now, sir?
No. Yes, key facts, yes.
Yes. So in India, about 3 to 4 people per 1,000 population need palliative care, and only 5 million people have access to it. So that is the vast difference of palliative care which is necessary in India. And why is palliative care necessary? Has the slide moved, sir?
No, now only the fifth slide is on. I think resume slideshow is there.
Playing the slideshow only, sir. Now, sir?
No, the fifth slide.
Should I play without the slideshow, sir?
You can click to the next slide. Yes, good. Why palliative care is needed? Yes.
So why is palliative care needed? Is because the changes in the disease demographics, where a lot of diseases of lifestyle disorders are increasing in number, and the rise of incidence of cancer and HIV/AIDS, where advanced incurable stages patients come to us, and increase in the life expectancy. If you see in 1990s, the life expectancy in India was around 57.86 years. In 2017, it has increased to 69.16, and changing the dying process. What do we mean by this is most of the people die in the hospitals, and increasing health, which increases the health cost. The slide has moved, sir.
Now, why palliative care is needed is the slide. It's the sixth slide. You have to click it on each. Yes.
Every time to move back. So palliative care involves a range of services delivered by a range of professionals which have equally important roles to play, including physicians, nursing support workers, paramedics, pharmacists, physiotherapists, and volunteers in support of the patient and the family. Palliative care is required for a wide range of diseases. And in contrast to what is the common understanding is palliative care is usually needed for cancer cases where there is less scope of recovery. But in actuality, if the statistics are saying cardiovascular diseases need more palliative care, around 38.5% of the cardiovascular diseases patients usually need palliative care, followed by cancer, chronic respiratory disease, AIDS, and diabetes. Pain and difficulty in breathing are the two of the most frequent and serious symptoms experienced by patients in the need of palliative care. For example, 80% of the patients with AIDS and cancer and 67% of patients with cardiovascular diseases or COPD will experience moderate to severe pain at the end of their lives. And opioids, as you all know, are the most essential in managing pains. So let us understand what WHO has to say of palliative care. If you notice, they have colored a lot of words in this. Each word is very important to understand the palliative care according to the WHO concept. The palliative care is an approach that improves the quality of life of patients and their families. So we're not focusing only on the patient, but their families as well, facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So it is an overall understanding of the person and their family. It is not focused only on the patient. Is this slide visible, sir?
Okay, visible. Yes.
Yes. So if I ask each one of you, what kind of death would you like to have? So most of you will think that this is not a right question, but quality of death is one thing which we are focusing on in palliative care, because all of us are focusing on quality of life. But when it comes to death, which is quite inevitable, there is also a study which is conducted which focuses on quality of death. And if you see, India stands at 67th position out of 80 countries which have been studied. So that is the amount of burden of quality of death which is seen in Indian scenario. Okay, so which also focuses on the human resources, affordability of care, quality of care, and community engagement.
The slide is not moving, sir. Please move the slide. Yes, yes. Indian scenario, yes.
I was talking about the 67th rank out of 80 countries, sir. So Dame Cicely Saunders, who was the first person to set up a hospice, this defines palliative care as good quality palliative care can be defined as the care which I would be happy to have given to a member of my own family if he or she was dying, or to receive myself when my time comes. So that is how important it is to understand why a good palliative care is the need of the hour. So when should palliative care start? The common notion of palliative care is when everything has failed, all the systems have failed, and that is the time when the patient comes to a palliative care specialist who has to take care only that the person has a peaceful death. But the new definition of palliative care has changed, the concepts have changed. So that is what I'll just speak about. So if you see this picture, the old concept usually had, is this visible, sir?
Yes.
So
When should palliative care start? That slide. 14th slide. Yes, yes, okay.
So what was focused earlier was palliative care is at the end of the life. So this triangle which you see is where palliative care was at the brink of death. But the new concept which is also has to start from right from the diagnosis. So the old concept usually was brink of death care, whereas the new concept is quality of life care. And the old concept mentioned that whenever the curative part is exhausted, that is when the palliative care started. But right from the diagnosis, the palliative care has to start. Because if you focus only on the last few years or few months of life, many opportunities of treating the person and his family and his background is lost. But now it covers all the stages of disease till the death and beyond. So you're not focusing in palliative care till the person dies, but also beyond, which we'll right now understand. So if you see this diagram, so health is where prevention is focused on. But once the diagnosis of any disease is made, just not cancer, try to understand this palliative care does not focus only on cancer, but any disease which is diagnosed for a person. So right from the diagnosis, there's this process. Okay, so this is the curative part where all the medicines and if at all it is a surgical case, surgical management, everything is done. Curative and life prolonged care, which includes symptom management, life closure, and end of life or dying period. Okay, so the palliative care starts right from here till this is the death, and after that till the bereavement. So this part is taken care at the hospice. So if you see this is the illness which is focused. Before that, it is health. After the diagnosis, the illness, the entire part of the illness has to be the part of a palliative care specialist. And after the death also, you have to take care that the family is also taken care of. So after highlighting these things, let me just take you through a few of the couple of cases which I have seen in my practice where if you see the title of my presentation, From Diagnosis to Bereavement, and if you see the previous slide, how a homeopath can contribute to the diagnosis is what I'll be focusing on. So this is a 3-year-old male child who was coming to me with recurrent allergic rhinitis. So he was quite a frequent patient. With this time, he had come with a recurrent fever since 1 month. And every time he had fever, was active. He had coryza and cough, and there was pain and tightness in the abdomen, which he was complaining of, a dull pain. And he had initially had diarrhea 1 month back with fever. And after that, his fever was coming and going, and he was treated with local doctor with antibiotics. And when he came to us, he came with this, investigated for the fever, cause of the fever. We found that he had anemia with a high WBC count with lymphocytes 90% and platelet count, which was 59,000 only. But if you see the malaria, viral and dengue tests were all negative. But on examination, his spleen was just palpable. So we started with, based on the symptomatology, belladonna and paramphosph 3x. But why was this picture coming was not clear, because the symptoms and the picture of the child was not so septic to be seen, where so much of WBC is raised, and the child was quite active when he came to the OPD as well. So next day we called him again. The fever range had come down because of belladonna and the paramphosph which was given. There was no abdominal pain. But on examination, the spleen size had slightly increased to 2 finger palpable, and the liver was 1 finger palpable. And the HP was there, but the total count had increased. Platelet counts were slightly less again. And we sent him for ultrasound, which showed hepatosplenomegaly, moderate range of hepatosplenomegaly. So we sent him for a second opinion in our hospital. A pediatrician had seen him, and he again repeated with investigations on the next day, because where the total count had again increased, but now you see the picture in the differential count, the lymphocytes had increased, and there was a lot of atypical cells. The sample was sent outside to confirm whether the readings in the lab were different or it was same. So this lab report showed atypical cells with a lot of leukocytosis, lymphocytic predominance, and marked atypical cells and reduced platelets, and it was advised for flow cytometry. So we took an opinion from hematologist, and he was referred. And the same day when he was referred, he was admitted for bone marrow cytology and flow cytometry, which diagnosed a Cala positive, which beta cell acute lymphocytic this leukemia. And the point which I am trying to focus is a case of fever which was not responding to treatment of antibiotics and everything. The red flag signs which have to be picked up. Okay, and from there, how do you diagnose a case which has to be, because we cannot be treating just the fever. We have to see why is this child suffering and what is the background, why this fever profile and everything has been showing a different picture without any septic focus in the child. So now the child was sent there and he was treated, and he is responded very well to the chemotherapy, and is now under remission. He regularly comes. But the question now which people might ask is why homeopathy was not tried. So in this case, what the child's father was a software engineer, and the facial expression showed that he wanted to have a complete solution of the diagnosis as well as treatment which he could afford. So now it is my role as a homeopath not to impose homeopathy on him, but to at least see that he gets the right diagnosis. Once you send to the hematologist, he diagnosed that it is the correct time that the child has been brought. A little delay could have caused later more problems. So that reason is where I could play at least a simple role of diagnosing the patient and sending him to the right doctor. The second case which I'll be treating, which I am presenting, sorry, is a case of a 45-year-old man who had come with us, who was under treatment for allergic rhinitis. And this was the period of second wave of COVID. And as a routine, we were screening all the patients for any symptoms of ILI, influenza-like symptoms. So this person, when he had come with cough and mild breathlessness. So as a routine, we investigated him for complete blood picture and X-ray. And X-ray showed a mild haziness in the right lower zone. But on examination, there was not much of changes in the respiratory system. But as a routine during that time, it was mandatory to send for a chest CT. So which we sent, and we found that there was a homogeneous opacity in the right lower zone, and the CT chest revealed that there is a CA lung, a small space occupying lesion in the right lower zone of the lung. So he was referred to an oncologist for an opinion, but again, the oncologist, who is part of a system in a hospital, he opined that the patient has come at the right time, so that we can resect the part of the lung, and then he might not need much further treatment as well. So I underwent surgery immediately, and after that he did not need any chemotherapy, neither radiotherapy. And after that he is still hale and hearty, and he repeatedly comes to us with basic cold and cough or other symptoms. So the point which I am trying to make is, when we are treating a patient, we have to select the patient, and that is the main aim of integrative medicine. So what I'm focusing is, palliative care can be a part of an integrative medicine, where we have to focus to send the right patient to the right place at the right time to the right care provider. So the right care provider could be yourself. As a homeopath, if you're confident enough that you can take up the case and treat it, then you will be the right care provider. But at least you have to see that the patient does not get delayed in getting treated. So that is the main focus of integrative medicine, where we have to align with the other systems of medicine as well, where we can take help from each other and try to see that the patient receives the best care. We should not be insisting on any system, and we should have a good rapport with the other systems of medicine. And that is what happens in our hospital, where we interact and try to get the best treatment available for the patient. So coming to the second part of the palliative care. So when I showed you the picture in the initial few slides of the palliative care when it starts, so I've shown you two cases where the diagnosis is what, as a homeopath, I could play a part in diagnosing the case and sending it to the right place. Now coming to the symptom management. This is a 17-year-old boy who had come with swelling of the left knee with since 2 months, and pain at the left gluteal region since 2 months. So if you see the history of the person, I'm not going into the details of the entire history, but I'm focusing on few things. That his injury to the right knee was by falling on a rod. And since that injury, he could not move his legs. And after that, he was diagnosed with a mild fracture and he was treated. But after a couple of months, he again was complaining of a swelling on the right knee joint, and he visited the doctor again, where he underwent 4 chemotherapies because he was diagnosed with osteosarcoma, and he underwent a distal femur megaprosthesis and took 9 chemotherapies and got relieved. And now when he came, after that, he again had injury to the left knee 8 months back. And again, he was diagnosed with a fracture for which he was treated. And he underwent a PET scan and came to know that there is necrosis happened at the left knee, and there was
The slide is not moving, sir. Excuse me, sir.
Oh.
Yes. Okay.
Now, sir?
Yes, yes. Yes, yes, good. Okay.
There's some problem with the system, I guess. So this person, when he came, before coming to us, he has undergone a mega prosthesis of the left distal femur. Then after the left knee, again he had necrosis, and there was metastasis in the lungs as well. which the PET scan had revealed. So when he came to us, he had come with swelling and pain in the gluteal region. So this was the investigations with which he came to us, which was already done, and he was diagnosed with osteosarcoma grade 3, and all this was already available to us in the beginning of the treatment. But when he came to us for pain management, right? So pain management is a very important aspect of palliative care, where a lot of morphine is what is given to the patients, because that is one of the opioid which is quite commonly available, but it is also causing a lot of other symptoms as well. But it is the most easily available and cheapest form of opioids which can be given to the patient, and that is usually given to the patients in the hospital, in the palliative care centers. So after this, when we came to us, we saw the symptoms, we saw the pathology, and when we repertorized and we came to the diagnosis, we referred back to the Materia Medica and we selected medicine called as Hecla lava, where Boric mentions that it is of great use in exostosis, gum abscess, difficult teething, nodosities, caries of bone, etc., osteitis, periosteitis, and osteosarcoma, arthritis, tumors in general, and bone necrosis. If you see the PET scan, there was already necrosis of the knee, left knee, and there was a diagnosis of osteosarcoma. Based on this, we have selected Hecla lava, and we started with the treatment. And this patient was admitted to see how this medicine is acting and how this patient progresses or responds to the treatment, because he was in severe pain. He had come in the wheelchair, and the patient's parents were quite anxious that at least you relieve the pain, because he was almost addicted to morphine, taking almost 4 to 5 times in a day. So that was the intensity of pain with which the person was suffering with. So we started with Hecla lava 6C, and as a complementary biochemic calcarea fluor also we started based on the pathology. And this was on 18th, then next day itself, he had complained that he was feeling much better. On 22nd, if you see, the pain had decreased and the morphine tablet had decreased to twice a day. Initially, he was taking 4 to 5 to 6 times a day. It has come to twice a day. He was able to sit for a longer time. When he had come, he was on the wheelchair, and immediately on putting on the bed, he was continuously lying down because of the severe pain. But now he was able to sit for a longer period of time. And a month later, his pain was much better. He was taking on and off twice or thrice a day, and the burning in the soles was completely better. And now those electric shock-like pains in the left toe, and he was continued with the same treatment, Hecla lava and calcarea fluor. And we took the details of the child because he was quite optimistic in nature. He wanted to study further. In spite of knowing the diagnosis, he was quite optimistic, and based on that, we repertorized this totality, and I started with phosphorus 30 as a constitutional medicine along with Hecla lava and calcarea fluor. So this morphine usage had by now come down to only once in bedtime. The shock-like pains were less, and bony swelling on the left wrist had appeared. So the metastasis is still going on in the body, and we see that left wrist X-ray is also already showing a metastatic lesion at the distal end of the radius. You see this X-ray? Is this visible, sir?
Visible, yes, please.
Yes. So this is the metastatic lesion which had developed in the wrist joint. So a month later, again, he came with the left knee swelling, which had increased, which had become firm. In between, we had asked to come for a follow-up, but he was not regular with the follow-ups. The pain now is very severe in the left wrist. Bony swelling was slightly better, and he was continued on the same treatment. Now, after this, which is quite common, is when the patients feel that there's some relief, but they still want hopeful of getting cured. Okay, even in incurable cases, most of the patients, it's quite natural for them to be expecting cure. So they disappeared for a couple of months. They did not come back. And after that, when they came back, this is the chest X-ray on the same day. And a couple of months later, he came back with a difficulty in passing urine. He has to strain to pass urine, and there was decreased quantity of urine. Low backache was decreased, left knee pain was decreased, but his bleeding tendencies had started now. Left nostril was bleeding. There was appetite which was decreased, and all this was along with the pain, which was quite severe, and with difficulty in urination. And we repeated the chest X-ray. And this is how the chest X-ray on the visit in July appeared. So the metastasis had increased quite severely in the entire lung fields. And this is how the pelvic X-ray appeared. So this is what was causing pressure on the bladder, which was having difficulty in urinating. And then this person was referred to a higher center for the further management of this condition, which continued the Hecla lava for the pain management, and he subsequently in a couple of months he expired. So this is how it appeared when he came in July after 2 months of gap. And this is the lesion in the left knee. So this is the third case which I'll be showing it to you. This is a known case of diabetes, hypertension, hypothyroidism. But now when he came, he had come with a diagnosed case of well-differentiated squamous cell carcinoma in the buccal mucosa because of past history of tobacco. He has undergone chemotherapy and radiotherapy, but when he came to us around 6 to 7 years back, he had come to us for treatment of diabetes and hypertension, after which, since this disease was diagnosed, he was treated outside, and then he came back for difficulty in opening of the mouth, because of which he was not able to chew properly, itching all over the body, and sleeplessness. Based on the symptom that all this has happened after radiotherapy, we started with radium brome. Okay, radium brome is one of the very important remedies which is very acting very well after radiotherapy, and this person over a period of time had improved, his jaw movements has improved, and then he was able to chew and swallow a little bit. But recently when he came last month, he has again developed a lesion in the opposite side, I think on the same side, and which was quite severe. And then he has undergone a surgery, and now he's coming for treatment again for the pain and improvement in the jaw movements. So what I spoke to you just now was about symptoms and symptom management in palliative care. And now what I'll be focusing is the last part of the bereavement. Bereavement is what we have, as we all know, that once somebody expires, we go there and console the relatives or talk to them. And what happens when, as physicians, when we see cases, we usually, after the patient discontinues, we fall short in not continuing with keeping in touch with the patients. So that is not what is expected in palliative care. When palliative care you take up as a system, you have to continue to support the family beyond the death of the patient. So that is part of bereavement, is a part of palliative care. So here are a few cases which I'll be discussing in very short, where I'll not be going into depth, but all these patients have expired when they were under my care or after the treatment here for the symptom management, they have expired. But what I want to focus right now is that these patients have been treated by us, and after the death of the patients also, the relatives have come back with other cases, and they have kept in touch so that other patients in their family can be treated because of the type of care we have given to them. So the first case is of a multiple myeloma with neck femur, a shoulder joint. He was a police officer. After retirement, he had developed this multiple myeloma. And whenever we were trying to move him, he was developing a new fracture. So conventionally, he was given on painkillers and traction, but when we focused and we took the case in detail, we started him on Symphytum 200 and calcarea pause. So after treatment for a couple of days in the hospital, we discharged him, and after a couple of months, the son called me and he was asking for some relief for his last moments in life. So that is when we advised for opium 6C, and this patient
Excuse
expired.
me, sir. Slide is not moving, sir.
Oh,
You have to go to slide number 45. Yes, yes, yes.
so this patient expired with peacefully, and after giving opium 6C. The next case is of hepatocellular carcinoma with CA duodenum, where chemotherapy was going on, and along with that, arsalv and carcinosin was given, and the pain in the abdomen was much better with this. The third case is of a small infant, a 3-month-old infant who had come with increase in the size of the head, the hydrocephalus, and that was diagnosed, and a shunt was already the stent was already placed, and the child was having seizures and he was on antiepileptics. So when they came to us, their main focus was the child should have a healthy life till whatever period the child is alive. So they were mentally prepared that the child cannot be cured completely, because that is what the pediatrician and the neurologist had told them. And this was because of a ependymoma in the brain. And we started the child on sulfur 0/1, then we continued with calcarea. And later on, when the child, this child was with us, the life expectancy which was given to us around 3 to 4 months. But this child was with us for almost till the age of 9 months, and after which the parents continued to stay in touch with us, and now they are blessed with a one more girl child. And the fourth case is of a cholangiocarcinoma. Here the chemotherapy is going on, and he has already undergone around 32 to 40 cycles of chemotherapy. This main symptom was constipation and bloating in abdomen, for which he was treated with naxomica and chelidonium, and he is still alive. This person is alive and was alive, and recently, after a period of 4 to 5 months, then he expired. The last case is of a 6-year-old girl who was already an operated case of medulloblastoma, but now had come with Wilms tumor. The child was on chemotherapy, and because of the pain in abdomen discomfort, this child was treated with carcinosin and phosphorus 0/1. And later on, the parents were not able to take care of the child in the house. They had other kids to take care, so they shifted the baby to a hospice where he died peacefully. So this is what, and after that also this patient was, the parents were in touch with us. And this is what I want to focus is, once the patient is treated amicably and with a lot of care, that is what the parents and the patient's relatives develop confidence in you, and the patient's relatives might come back to you with some other illnesses. And that is how you build a rapport. And rapport building is quite essential in homeopathic case taking, because that is where the patients develop confidence. And after confidence is developed, even if you give placebo, the patients feel much better. Then what we have observed is placebo also plays some role in treating in between when the patient is feeling much better with the deeper acting constitutional medicines. So what are the take-home lessons from today's presentation is that pain relief is a major concern in palliative care. And nowadays, palliative care mentions that along with the vitals, that is the temperature, pulse, BP, the fifth element which has to be added is pain. So pain becomes a vital sign in cases where palliative care is delivered. And homeopathy has a great scope in pain relief and palliative care, which needs to be explored, with a lot of people taking up palliative care, not just in treating the symptoms and the disease, but also in keeping in touch with their patients on a regular basis and trying to give them as much as empathy as they need. And integrative medicine is the need of the hour, where you have to align with other systems as well, other systems, which I mean the modern medicine as well as the Ayush systems, where the best which is available to the patient and which can be, the patient is having a choice to select, that has to be given to the patient. And individualized homeopathy will be very useful as an adjuvant to the conventional system of medicine, where the patient need not discontinue because once he has started, if the patient has come to you in the initial phase and you have seen that the patient is, you have seen previously that such diseases have been treated in your own private practice or your hospital practice, then you can take up the case right from the beginning without going for any modern medicine. But once the patient has already started, it will not be wise on our part to stop those treatments. But as an adjuvant, homeopathy, individualized homeopathy will definitely be helpful in at least taking care of the symptoms and prolonging the lifespan and taking care till the patient has been with us. And understanding the pathos of the patient and standing by them and their family beyond bereavement. So if you focus on those colored letters, so understanding the pathos is not just understanding the pathology of the person, but also what is happening with the patient's mind. What is he feeling? What are his thoughts about life and death? So these are the things which we have to sit down and talk to them and take them through this journey, painful journey of reaching till the end of life. And after that also we have to keep in touch. And during the treatment also we have to be constantly supporting the family members who will be relying on you for not just cure, but also symptom management. And this is an important task which the doctors have to achieve. So homeopathic teachers, I'm focusing more on now the institutions where colleges are run, homeopathic hospitals where colleges are run. So this slide is addressed to all the teachers. Homeopathic teachers should show the relevance of keen observations. Whatever I've shown cases today is all mostly on observations, because if you see, the susceptibility of the patients is not that good enough to throw characteristic symptoms. And without the characteristic symptoms at the end stage of the diseases, what you have to rely on is pathology, the pathological symptoms, pathological generals, and your keen observations, and impart or demonstrate knowledge about bedside clinical training. So all this can happen when you have a good setup where patients can be seen day in and day out, and you are able to see the changes with your medicines. After each dose, what is the change the patient is experiencing? After every next day, what is the changes observed? So this will also help you in moderating or modulating the potency selection, and if necessary, the changes in the medicine with the follow-on remedies. To demonstrate the importance of knowing one's science and its scope and limitations. So let us not focus only on that everything can be under the sky can be treated with homeopathy. We do have a scope, we do know our limitations, and that is what has to be imparted to the students, where they understand what cases have to be taken up and what cases have to be kept away. And one should not leave the relatives alone as soon as the patient expires, but help them overcome the shock, the grief, agony, sufferings, etc. And these are all symptoms where homeopathy has beautiful results. So let us try to help the family as well, where all the symptoms of after the death of the patient can be treated with homeopathy. And empathy cannot be taught in classrooms except for the definition and meaning, but has to be demonstrated in clinics, OPDs, IPDs at the bedside. And this is, like I told you, this is what homeopathic teachers, we as homeopathic teachers have to train and impart knowledge to the students who come to us. So this is acknowledgement to my director, Dr. Naveen Pavaskar, and the entire team of house physicians and interns at King's Hospital, without whose close observation and keen observation, we could not have seen what best could be done to the patients, and all the patients who still instilled confidence in me to be a part of their enduring painful journey, and of course to IFPH for allowing me to share my experiences in palliative care and what is palliative care and what needs to be done in palliative care. So these are the references. And before I end my presentation, here is James Cecily Saunders' very famous quote, which is very quite important in these days where palliative care has to be focused on. And I read a quote: "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." With that, I end my presentations. If there are any questions, please.
Okay, thank you, sir. Your wonderful presentation, valuable one, especially the last part is excellent because don't leave the relatives of the patient after the bereavement. It is a quite novel idea you are providing, because, and of course, homeopathy is a science which can provide definitely some medication to the patient, the bystanders as well as the friends and relatives, definitely. Then another one is very remarkable point you mentioned is the empathy. It
Yes,
should be taught not in the classrooms, but in the bedside or in the clinical classes. So
yes,
wonderful conclusion. So time for discussion. Those who would like to participate, please raise your hand. So I think you can close your screen share.
yes, sir.
I shall do, don't worry. Okay. Yes. Dr. Hemraj, do you have anything to ask? Dr. Hemraj, raise the hand. It is by accidentally happened or please, Dr. Hemraj, are you there? Not responding. If anyone would like to participate, please raise your hand. And they mentioned about the demographical aspects of this palliative care. I think 3 to 4 persons in 1,000 is subject to this condition. I think it is otherwise. It's more than that. Around 30 to
Yes,
40, especially in this era, with the new generation, the children are not there. They are going abroad. Definitely,
yes,
the parents, there will be nobody to look after the elder parents. So definitely, its magnitude is growing, growing, and growing. Then you mentioned about the percentage of patients who are mostly affected is 38.5% case of the cardiac disease, and around 34% case of ischemic malignancy, and 10% lung disease. Then the rest of the disease are constituted other one. When you mentioned about this, the etymology of this palliative care, this to be cloaked or concealed, it's a palliative. There's also, because you are a college professor, that is always needed. Then you present a couple of cases, and what is mentioned is that more important is that the individualized medication is more important, as you rightly mentioned.
yes,
But it is not easy. Moreover, once the case is diagnosed, quite natural that the friends or relatives will pressure the doctor. That will definitely bring down his confidence. That's the most dangerous situation. That is, you cannot tackle on these things. Then the pain relief, then integrative medicine, that another point. Where to give, what medicines, which type of medicine is needed. And often I think the continuous medication with medicines other than homeopathy is often leading to such a condition, because no other medicine will respond because they are regularly taking the medicine. The
yes,
physician will advise, don't take, don't stop, don't stop. But who know what happens? Definitely the complication, because there is no relation between the medicine and the disease. Then another point is about that the homeopathy also, we are following the same law of similars. That
yes, sir.
also have to be followed, as rightly mentioned Dr. Kent. That is for palliation, curative treatment, we should adopt only law of similars.
Yes,
But what is difference is that the advancing pathology, then the potency, dose, repetition, attenuation, as well as the acute disease or chronic disease, depating, anti-asoric medicines. Well, these are more important in such cases, I think. What is your comment on that, sir?
I didn't get you, sir.
Yes, the medication, it depends
Yes,
upon the potency, dose, repetition, all these things.
yes, sir, definitely. Because individualization will also focus on all these things, and depending on what is the need of the patient, we have to modulate the dosage, potency, and how frequently the medicine has to be given, and see the response. So we cannot, in such cases, we cannot send the patient giving medicines for 1 month or 2 months. We have to keep on following these patients regularly to see whether the medicine is acting, whether the patient is responding, whether the body is able to accept that medicine and respond to the medicine. The susceptibility is at such a low way that you have to take care that the susceptibility is aroused so that it can respond to the medicine power. So that is when the body can respond and produce symptoms or take care of the symptoms by itself. The vital force has to be supplemented with the right choice of the medicine and the right choice of the potency as well as repetition. Then only the vital force can take care of the body in improving the immunity status as well as the management of the symptoms.
Definitely in Kerala, we have a separate hospital government sector for this cancer care at
Yes.
Manappuram, this Chedana is time. And then what is more important is a lot of homeopathic physicians are doing wonders in this areas, but it is not at all properly connected.
Yes.
That's the most important thing.
I'm currently doing a founded this fellowship in palliative care
Yes,
from NAPCAM.
yes, yes.
That
And
is
recently the National Council Homeopathy is likely to start this diploma, this DM in palliative oncology. The coming years, I think
Yes, sir.
it will start. Dr. Shaji, could are you there? It's a pioneer in treating, more focusing on this, managing this cancer case. Dr. Shaji, could you? He is from Philippines. It is well past midnight. Dr.
Yes,
Shaji,
doctor, I am here,
yes.
but I didn't listen. I am sorry, I entered late, so I was unable. I am unable to comment on the today's presentation. I'm very sorry for that. I just ended, so very sorry for that.
What is your view regarding the prospects of the management of the malignant the cancer case as palliative care?
Yeah, definitely. Cancer is very manageable, and our medicines are working. Personally, I am working not only with the medicines, I am introducing a new approach towards cancer with the introduction of a new scientific hypothesis called dynamic science that explains how the mind, vital force, and DNA are interconnected. I call it dynamic science. And so I understand how cancer develops and explain to the patient and family and help them realize the root causes from all possible dimensions that produce the cancer, which help me in helping the patient and family in identifying and correcting the root causes that produce the problem, along with our medicines that is more complete in its sustainable cure. And I am getting very good results, and I am spreading that. I have given my presentation also in this forum. And so homeopathy and our approach is going to make a great way and for great future for homeopathy in the near times coming.
Okay. Then, Dr. Mohammed Irfan, what about the dietary management in such case you adopted? Do you have any suggestions or?
Frankly speaking, sir, I don't advise very drastic changes in the diet. Whatever is easily digestible, whatever is easily available, that is what I advise them to take care. I don't have separate diet plan for these patients. I'm not trained in nutrition, so I don't jump into that forum.
I think we must follow the Hahnemann instruction there also, because he is a master observation and he is also a scientist also. So definitely in chronic disease we can see a lot of instructions are given, and that should be strictly followed. I think that's my opinion in that case. Then again, the coming days definitely we know about the importance of this the genetic medicine, and
Yes.
as well as the individualized management. We all know that these are all the manifestations of the genetic factors, the disease, the individual symptoms. So definitely homeopathy is I think will be in forefront in the coming days to treat such cases. Anybody would like to participate, please raise your hand. Dr. Ram Parveshra, are you there? Dr. Ram Parveshra, are you there? Definitely, the viewpoint of the homeopathy fraternity must change
Yes,
because there is a sort of lethargy in everybody. They are not at all applying your brain 100%. Even attending a discussion, you are expected to participate also.
yes,
Otherwise, this will not grow. Because all persons are highly experienced, but everybody knows that they have their own experience, their own viewpoints. So,
you have to
don't
share
you
the
like
knowledge.
to comment on the rest, sir, please?
You have to share the knowledge to the next generation so that they can also start
Yes.
thinking at least what is possible. It's not to spoon fed them, but at least they can start thinking what is possible and what can be done in this area.
I think there is some problem. There was some problem in your education system because there was no such seminars or interactions or discussions are there. But recently they have started, they have realized that, recognized that.
Yes,
So in the coming days, in the coming next 5 or 10 years, the new generation of homeopaths will definitely able to communicate or convince others with our views,
yes,
especially when the PhD courses as well as this DM courses will start.
yes, sir.
Definitely in the coming days it will be more progressive. And what about the prospects or the progress of your college, Hyderabad, Dr. Mohammed?
Yeah,
Please.
we are doing very good, sir. We have now in the 10th batch of UG and 4th batch of PG with 100 seats in UG and 54 seats in PG. And next year we'll be adding a few more seats, and that is doing wonderful. We recently had the university results with a 100% result in all the exams.
Yes, definitely. Hyderabad is one of the famous cities of homeopathy for India, especially the Ramakrishna pharmacy.
Yes,
A lot of experience is there. A lot of well-known physicians was there now. There at that time. I hope so. The coming years also. If anybody would like to participate, please raise your hand. 1 or 2 minutes remaining. You have the post-graduation course. What about the PhD? Is there?
PhD is starting next year, sir. We still don't have. We have PG straight.
Next year, yes, we are facing a major problem because we don't have enough guides as
Yes,
well as persons who are called eligible for with enough publications in this peer-reviewed journals. We don't have
yes,
journals. So what is needed? Total reformation, revolution is needed in case of homeopathy in medical education. So the possibilities are there, the potentials are there, but it's not at all utilized. That's a lot limitation we have. I
yes.
hope that the coming days will be succeed in that. Time for in this discussion. I think Dr. Shadi could you there to express a lot of thanks. It's the Vice President of IFPH, Dr. Shadi.
Yes, yes, doctor. I am in a little outside, so I will not open my video.
No
So,
problem. Yes.
Dr. Muhammad Irfan,
Sure.
thank you very much. I understand you talked about cancer and its management through homeopathy today. And I think we homeopaths are very much capable and competent to do that. In Kerala, there is a government-based hospital for cancer treatment. I
Yes,
think we should expand such facilities to all over India, and India has to become a model for the whole world.
yes,
So great future is awaiting for homeopathy, no doubt in that. So we appreciate your presence in our forum. We expect more presentations from you and also involvement of the students of your institution in in our daily Zoom meetings, so that your students can understand and listen to our faculty presentations, which and also there are YouTube uploading of our video. People,
okay.
the students and others doctors can watch it daily also. So thank
Definitely.
you for this presentation. We expect more cooperation and coordination
Yes.
from you and your doctors and college students and teachers in the future activities of IFPH. So I thank
Definitely, sir.
you for on behalf of IFPH and all those who listen to you today. A great thank you for you. Come back again with a
Thank
more
you. Sir.
support and participation for the promotion of homeopathy nationally, locally, and internationally. Thank you,
Okay.
doctor.
Definitely.
Yes. That's all for today's English edition. Hope you that will be back again tomorrow. Till then, goodbye, and Dr. Shaira to continue the program in Malayalam. Thank you.
Thank you, sir. Thank you.